You know, all type 2 diabetics are not created. In fact, all type 1 diabetics are not created the same. Type 2 diabetes is a different disease. There are more defects in metabolism. In fact, a well-known researcher has said there are 8 major factors that he calls the ominous octet. And so many things that are wrong. See, type 2 diabetes is really a different creature. The end results of both uncontrolled type 2 and type 1 can be the same, say diabetic eye disease, diabetic kidney disease, but there are different ways, and there are different ways of approaching it. It really is a different disease with some of the same long-term complications. There are a number of things you could do there. First of all, one of our basic medicines in type 2 diabetes, Metformin, clearly helps people with type 1 diabetes. No question, a number of investigations have shown that. There is a newer one, you're seeing advertisements every night for, again, if you want to hear the brand names, Invokana, Farxiga, and Jardiance. Those are the 3 that are released. And they make your sugar, you spill more sugar into the urine. You can use those in type 1, but you've got to be very careful if you do that. Metformin is a safe way to use an oral medication for type 2. It's not widely done. I think you'll find most clinicians do not even use metformin along with insulin for type 1s, but you can do it. The chief misconception is just what I just said. All type 2s are not created the same. How is it that you have someone with type 1 diabetes for 62 years without any evidence of heart disease or kidney or serious eye disease, and yet you have another one with diabetes for 22 years who's ready for dialysis? Because they're not all the same. So the first misconception is all diabetes is not the same. The second misconception, and this one drives me crazy, is a fatalistic attitude towards it. And by that I mean that there's nothing you can do about it. I mean, we have so much data. For instance, right now in this hospital, we have what, 500 or 600 medical beds? We have, right now, upstairs, there are 80 people with diabetes. A good number of them have had surgery. Controlling blood sugar well, not even necessarily tightly, well, prevents surgical site infections. You can't argue with it, it's true. That's another, well, I'm not sure it's a misconception, but maybe not as well realized as it should be. More and more people are treating people with pre-diabetes. We did something in our hospital, and what we did is every person that came in with either what we call an acute coronary syndrome, unstable angina, or a documented myocardial infarction, a heart attack. And we did an A1C on every one of them. You know what we found? 6% of them did not know that they had diabetes and didn't know it. So that's really something. Now, you can then treat them because they already have it, but a larger proportion have what they call dysglycemia, that they're abnormal. So the thing is get those type 2. One thing I tell my colleagues, I work in an office with a number of internists, is that if you see that they're mildly hyperglycemic, their A1C is in that gray zone, start treating with metformin if there's no reason not to do so. Now, for type 1, it's a more complicated answer. We know that we can predict who has type 1 diabetes. There are any number of trials that have looked at immunomodulation and immunosuppression on already diagnosed type 1 diabetic children. Now, that may be too late, because the process, when you're first diagnosed with type 1, the destructive process may have already proceeded too far. The thing is to get those younger kids as they're going to develop diabetes and treat them. And that really, the future of the treatment of type 1 diabetes is to find out who's developing it before it develops, because even right now, we know we can at least slow the process with safe therapies. The treatment for type 2, well, I said it before, primarily insulin pumps, I suppose. If you go upstairs and you talk to our chief of pediatric endocrinology, he's a pump maven. I mean, he'll put anybody that moves on an insulin pump, and I exaggerate to make a point. He wants to put, in his group and other endocrinologists that work with him, they would like to get all their young kids on pumps. The better the control that you get, the earlier that you start doing it, the better that young person is going to do. It's changed in the sense that there are more things that you can do. You know, I don't want to say how long ago I started doing this, but it was a while back. And basically, what did we have? We had plain old unreliable NPH and regular insulin. Yes, and it was from animal source. I go back that far. And it was unpredictable in the way it was absorbed, and all you could do was give that, or what we call sulfonylureas, the old micronases and diabetic, glyburide, glipizide, and so on. And now you have oh heck, you can use something like a lipid agent, like colesevelam, which is calls the brand name of that, is a lipid agent. That reduces blood sugar by binding cholesterol in the gut, and also it reduces blood cholesterol and blood sugar at the same time. So there are a lot more options to use. In fact, if you look at the table that tells the average practitioner what to do when they first diagnose a type 2, it starts with metformin and then has branches that go like this. It's a very, as they say, a busy table.